Thank you very much for coming to this Care First
Shingles and
virtual
COVID.
health platform. Today is February 4th, Thursday at 11. We have Dr. Christina Lee for a tale of two viruses, shingles and COVID-19. So here you go, Dr. Lee.
Okay, thank you for the introduction. So I have the privilege of talking to you guys this morning about two viruses that is actually of interest to a lot of seniors, shingles and COVID-19. So I'm gonna go through kind of the overview of both viral illnesses. So for each one, I'm going to talk about the cause, how it presents, like the clinical symptoms that you might show up with, some of the complications that can happen, as well as risk factors that might predispose you to these illnesses. And of course, we're going to talk about diagnosis, the treatment, as well how to prevent it for both of them. And probably going to be spending the bulk of the time more on the COVID, just because it's a newer disease. There's more interest in it, I think. Okay, so first we'll start with shingles. So as some of you might know, it's actually a virus that causes a painful rash. In Chinese people, I know a lot of people will say it looks like a snake because it happens in a linear pattern. And it is a very common illness. Up to 1/3 of Canadians will get shingles sometime in their lifetime. And I've had patients who can get it more than once. It's possible. We're saying that the pictures below actually depict kind of what you might see. So initially, it might be the picture on the left where it just kind of looks red. And then sometimes you'll form blisters, which is the picture you see kind of in the middle. And then when it finally kind of dries up, it'll look like it's scabbing on the right side, that picture on the bottom, okay? So the cause of shingles is actually the same virus that causes chickenpox. It's called varicella zoster virus. So anybody who's ever had chickenpox as a child has the potential for developing shingles sometime, later on. And it's said that anybody born before 1980 probably already had chickenpox as a child. Even if you don't remember it, we can assume that you probably had chickenpox. So you're at risk for developing shingles. And what happens is that once you had chickenpox, the virus actually, even though your immune system kind of clears it can still lie dormant, which means it's kind of like sleeping inside your nervous system in the spinal cord along the back. And it can be dormant for years and years and never reactivate. But for some people, it can become active again. And then it will travel along the nerve pathway, the spinal nerves, and this will manifest itself on the skin. So how it presents is usually the pain and burning or tingling, numbness, and sometimes you don't see the rash, you just feel pain, and that's the first symptom. So sometimes the doctors may be perplexed as well. We might think it's something internal, when it's actually later on the rash will show up. Sometimes people will have sensitivity to the touch, then a few days later they get that red rash. And like I said, it could just be red spots first initially, but then later you might see blisters. It could be itchy, you may feel unwell, like you might have a low-grade fever, you could have headache, a malaise, feeling fatigue, kind of like when you get a viral illness, right? And then there's pictures on the, showing the typical, pictures. So the one on the chest is the most common, but then it can happen on the face as well, as you can see on the right side picture. In that lady, it's affecting almost the eye picture, area. So I will talk a little bit more about that. So the rash usually follows, like I said, the nerves, spinal nerves, and what we call them dermatomes, because every level of the spine, starting from C, it goes out all the way down to L, the spine, you can see the distribution there. And most commonly, again, it's along the torso and only on one side of the body. It shouldn't really happen on both sides. I know there's some misconception or myth that, oh, if you get it on both sides, you're going to die. And I've never seen that personally. So it should be only one side, and it respects the midline because there's nerves on two sides, and it should only affect one side. The only time that you may have more like a disseminated pattern is if you're immunocompromised. If your immune system is weak, then it might not be able to fight off the virus very well, and then it'll look almost like chickenpox. So it's all over the place. It's still, then it wouldn't be kind of following that nerve dermatome that I was talking about. And like I mentioned before, it can happen on the face. So in the face, you can see on the lower picture, there's 3 spots that can happen, the V1, V2, and V3. So V1 is the one that sometimes we worry most about because it can affect the eye. And in that case, sometimes you will have to see an ophthalmologist to rule out any damage to your cornea, which is the layer covering your eye. But I've seen cases of V2, V3, and they can affect the ear. Some people get really bad blisters and swelling of the ear and pain, and it can affect the hearing as well, temporarily. So like I mentioned, there are certain risk factors for developing this kind of disease, and age is probably the most well-known one. Anybody over 50 is at risk, and this risk increases the older you get. There are certain diseases, that weaken your immune system, such as HIV, or you've got cancer, then it also weaken your immune system. So you might be more likely to get shingles as well. And then related to that is if you're undergoing certain cancer treatments, such as chemotherapy, radiation therapy, your immune system again is affected or suppressed. And then for some people, if they've had transplants or if they're got some autoimmune disease where they're taking these immunosuppressive medications like steroids, then they are at higher risk of developing shingles. However, I've seen cases in younger people, 30, 40-year-olds that can get shingles, and sometimes it's just due to, stress. I've seen that happen too. So it can happen at any age really, but definitely older you are, more likely you're at risk. So some of the complications of shingles include, the first one is the one that most people fear. It's called post-herpetic neuralgia. Means that you get chronic pain that persists even after the rash is dried up and cleared. And this is due to the virus causing damage to the nerve fibers. And it can affect up to 20% of people with shingles. And the risk is higher again if you're older and you get shingles. So I have people who get pain continuously after like a year of the shingles onset, can persist, and sometimes people even need to take painkillers for that. Another one, if it's affecting that V1 dermatome that I mentioned on the face, then there is a potential for vision loss if the virus affects the cornea, like I said. So that's when you definitely, if you see shingles on the eye area, on the upper forehead, you need to see an eye doctor for that, okay, to get it checked out. And then it can, because it kind of resides or dormant in the neurological system, it can also affect the nervous system. So it can cause inflammation of the brain, encephalitis, or it could temporary facial paralysis or hearing, like I said, if it affects the ear. And then sometimes the skin, because it has blisters and, if they pop or you scratch it, then sometimes you can also get bacterial infection on top of it. And then another, risk is that, even though you have shingles, you can potentially spread it to other people, who are not immune to chickenpox though, okay? So shingles is not spread by just direct touch. Like you don't get shingles from shingles usually. You can only get chickenpox from shingles if that other person has not had immunity to chickenpox in the past. Okay, so the only way to get shingles is if you had chickenpox and then it reactivates. Hopefully that's clear, okay? I know it's a misconception too. So for the diagnosis of shingles, it's usually a clinical one. The doctor sees a rash. It's a typical, following that nerve distribution. You see blisters or red clusters of these rashes. Then we don't really need to do any other tests. We just clinically diagnose it. And like I said, shingles can be contagious, but so you should keep the rash covered if you can and avoid contact with anyone who hasn't had chickenpox. And this is especially true if it's people who are have weakened immune system, like the people on chemo or cancer patients or pregnant women, and definitely newborns who haven't had the opportunity to get the chickenpox virus, the vaccine, sorry. And for treatment-wise, shingles can be treated because it's a virus. There is antiviral drugs that can be taken to help speed up the healing and reduce your risk of complications such as that chronic pain, the post-herpetic neuralgia that I mentioned before. However, to be effective, it has to be taken within 72 hours of the rash onset. Otherwise, it may not help much. And then usually, even if you pass that 72 hours and you still have the rash, it will heal on its own. Usually, it just dries over, and most of the time time, people don't have any consequences from shingles. But for the pain, you can take painkillers, analgesics. Some people might need Tylenol 3s or stronger painkillers to help with the pain. So for prevention, as you might know, and some of you might have gotten, there are shingles vaccines. So there's two brands available in Canada, Zostavax and Shingrix. Zostavax is the older one, and it's kind of fallen out of favor just because it's less effective. And the Shingrix is the newer one that came out a couple of years ago. And both of them are indicated or recommended for people over 50. So we don't really give it to people younger than 50, even though I have some people ask about it. And they are covered by OHIP for anybody who's between 65 and 70 years old. The only thing is that before, public health used to only provide Zostavax, so the older one that only required one dose. But now they've actually been changing it. They're trying to transition now to the Shingrix, a newer version, because it's more effective. So if you had Zostavax before, the old one, you can still consider getting Shingrix to get extra protection just because it's more effective. Okay. However, if you got the Zostavax for free public health before, like because you were 65 and you got that one, then you're not eligible to get the Shingrix for free now. Just because they won't let people double dip, I guess. But if you never had the old one and you say you just turned 65 this year, then you should get the Shingrix. And that's the only one that's available now anyways. And for both of these vaccines, the most common side effects are just local, like mainly redness, swelling, a little bit pain, and itchiness at the site of injection. Occasionally, people may get kind of a low-grade fever for 1 or 2 days, and headache, and just feeling a little bit unwell. But yeah, it's usually well tolerated. So here's a chart. It's kind of comparing Zostavax versus shingles. So like I mentioned before, Zostavax, the older one that has only one dose, it's actually a type of vaccine that's called live attenuated vaccine. Means that they actually have the virus in it, but it's weakened so that it doesn't actually cause disease. Okay, so like I mentioned, it wasn't so effective. It was only reducing your risk by about 50%. And the older you are, they're even less effective. That's why the government did not pay for it if you're over 70 years old. And the one of the reasons that you cannot get the Zostavax in the past is because, well, other than the fact that if you're allergic to vaccine components of it, other people who are immunocompromised also couldn't get this because if it's a live vaccine. So if you get it and your immune system's not strong enough to kind of fend it off, then you could actually get chickenpox, rash, and actually cause illness. In contrast, Shingrix is a 2-dose vaccine. So the second dose is usually given 2 to 6 months later. If you kind of miss the 6-month mark, it's fine. People will still catch up because especially during pandemic, we've had people who kind of miss that 6-month mark, but it's okay to still get it later. Up to a year later is fine. And this is not a live vaccine, so it's inactivated. It's just a part of that virus. So it's definitely not the whole virus, and it's not live. So this one does not have that contraindication, which means anybody can get it unless they've had allergic reaction to it. Okay, and this one is 90% effective, and it's effective even in older people who are over 70. However, public health still only covers this vaccine for people between 65 and 70 as of now. Okay, so what my message would be for shingles is that, there's a vaccine for it. It's good for prevention. It's not 100% effective though, so it doesn't guarantee you won't get shingles, even if you get the vaccine. And I've had cases like that where people still got shingles afterwards, but it will be much, much milder. So you won't get as much pain and suffering. And so I would recommend that everybody, talk to your family doctor about getting the vaccine, especially if you're over 50 or your immune system maybe it's just not so good. Okay. Now we're going to switch gears and talk about COVID-19, which is obviously a hot topic because it's been affecting us for the last year or so. And as you all know, probably this is a new virus that was first detected in China in December of 2019. It was causing a lot of severe pneumonia, atypical pneumonia, and that's why it kind of became, well known. Unfortunately, because of air travel nowadays, it basically spread globally to every corner of the earth, now even Antarctica. And now we're in the this pandemic, current pandemic that hasn't abated yet. The name is actually derived from coronavirus disease 2019. So the highlighted red is where they got this COVID-19, and it's named by the WHO. And it's been found to be more infectious than the flu, and that's why there was more concern about it. And it also caused a higher death rate than the flu. And there's a picture now on the bottom that I kind of showed. Like on the left is like almost a normal chest X-ray where you see more of a black in the lungs because it's filled with air, right? It's black. But when you have that bad pneumonia, basically becomes all white, patchy white, and that's from filling with fluids, from inflammatory cells and things like that. That basically becomes consolidated picture, and that's what happens when you get pneumonia, and that's why you can't breathe because there's no air getting through. And the cause of COVID is the coronavirus, and it's called SARS-CoV-2. So it sounds a little bit like SARS because it's in the same family as the SARS that happened way back in 2003. It's a coronavirus, and it's the same virus that also causes MERS, which is the Middle Eastern Respiratory Syndrome that some of you may have heard of. And it's this virus that has this crown of spike proteins on the surface. So it kind of looks, I guess that's why they call it corona, like it looks like a crown. And it's mainly spread, we believe it's spread by respiratory droplets and close contact, meaning you're close to somebody, they sneeze, or they're coughing, there's stuff coming out of their nose, these droplets land on you and or into your mucous membrane, meaning your eyes, your mouth, or your nose. That's how you would get it. There is some evidence, though, that under certain conditions, it can be airborne. The WHO does mention this as a possibility, but it's pretty rare because if it was really airborne, there would have been way worse kind of pandemic than it is now. That means like more people would have been infected. And I mean, it has been kind of documented, but it only occurred when they were in really enclosed spaces and there was like poor air ventilation. So in most cases, it's still by droplet and close contact with somebody who has symptoms. Okay. So the presentation, as you may know, it's actually very much like any kind of respiratory virus. You can have a wide range of symptoms, and the symptoms may not show up right away. Like it may happen even after up to 14 days after the exposure to the virus. And that's why, when people are traveling, coming back, they quarantine for 14 days because it can still happen up to 14 days later, the symptoms. So the typical symptoms would be fever, a cough, and difficulty breathing. But, it could even cause fatigue, muscle aches, kind of like flu-like illnesses. So you can get headache, sore throat congestion. You can even get nausea, vomiting, diarrhea, abdominal pain. And then the one that's more kind of specific for this viral illness is the sense of taste and smell may be altered, or you might lose it. So that might be, a clue that you might have COVID, actually, if you don't have any of the other typical symptoms. And because the symptoms are, like I said, very similar to other cold or flu, it's really hard for us to tell based on the symptoms alone. And that's why testing is actually kind of important in this case and may be needed to differentiate. So for risk factors, there's risk factors for catching the virus, and there's risk factors for having more severe illness. So older people and people who have any kind of underlying medical problems, such as lung disease, heart disease, diabetes, they are a higher risk of developing more serious complications from COVID. So are pregnant women. They've been documented to be having more ICU kind of stay if they get COVID. And then some other people, such as the indigenous population, certain ethnic minorities, such as the Black population, some Southeast Asians, they can get kind of sick too, actually pretty sick compared to the Caucasian population. But then there are the people who are just a higher risk of catching the disease because of their work or where they live. So these include healthcare workers, people who work on the front line in the grocery stores and the pharmacies, essential workers. Just because they have to be out with other people, they're at risk of catching it, but doesn't mean they will get more severe disease unless they have the underlying medical problems or older age. And again, similarly, people who live in long-term care homes or congregated settings, meaning like a lot of people in a small kind of area or shelters, then they're at higher risk of catching it as well because it can spread like wildfire in those kind of circumstances. So complication-wise for COVID, obviously during the acute illness, some people will develop pneumonia, respiratory failure, meaning they can't breathe on their own. They might need help with that. They can have cardiovascular issues such as developing higher risk of heart attack, heart failure, inflammation of the heart, or developing blood clots that can be kind of serious. And neurologically, like I said, some of them will lose their sense of smell or taste, and that can last for sometimes weeks to months before they recover. And then they've noticed that some people may have cognitive deficits, so they may have more foggy memory, a little bit of memory loss, problem processing things because of COVID. And after, even if you've recovered from COVID, some people will continue to experience other long-term issues. So fatigue is a very common one that people complain about. They may be tired, they're not the usual self. If they had the lung issues, they may have reduced lung capacity. They may continue to have shortness of breath or chest pain for up to a year even after COVID. Some people can get joint pains because the virus for some reason causes inflammation in a lot of parts of your body. It's been said that sometimes your cholesterol or sugar metabolism can also be affected by COVID. And then another big one that people do experience is depression or anxiety, or even post-traumatic stress disorder because they've been, placed in the ICU, or if they had been intubated, then they can have more of these mental health issues, especially if they were isolated for a long period of time. So for diagnosing COVID, there are different kinds of tests available. The gold standard is the nasopharyngeal swab test. That's the one that you would get if you go to the assessment centers, for example. And it's definitely the most sensitive in picking up the virus because it's said to be 95 to 98% kind of sensitivity, but it's obviously very uncomfortable and some people actually really can't deal with it. Right now, it takes about 1 to 3 days to get the results back from the public health lab or the local labs. And it is the test that's covered by OHIP if you fulfill their eligibility criteria. So right now the eligibility criteria includes anybody who's got symptoms, anybody who might have been in contact with a positive case and been told by public health to get tested. And then there's certain other, populations that are being targeted like long-term care, people, seniors that are higher risk. So that's the gold standard test that usually we do. The second test, it's available but not widely used, is the saliva test. So obviously it's less invasive, less painful. You don't have to poke, a swab through your nose. And so it's more suitable for kids or people who really do not want the nasal swab. The sensitivity is comparable to the nasal swab, and it is also covered by OHIP, but it just only certain labs do this, so it's not widely available. Okay. And then there's talk about these rapid tests. I don't know if you heard of it in the news, and the government still really hasn't implemented it very well. It is less sensitive, so it's only about 90% accuracy in picking up the virus, and it still requires a swab from the nose or the throat. But the only benefit is that it's actually, you can get the results quicker within 30 minutes. So I think some of the uses that they're using this in is in remote areas where they just don't have access to laboratory testing, or certain places like they were talking about possibly for airports or maybe schools where you want to know quicker. And some of the long-term care homes, nursing homes, they might also use this to know quickly if there's an outbreak in that home. So again, for most of the population, probably we won't be using the rapid test. It's a little bit less sensitive as well, okay? And then there is also the antibody test. So this is the blood test that, usually we do for other, viruses if we want to check if you have antibody immunity to a certain virus. So this is different though, because from the above test, because it's not telling you if you have the virus now. This is telling you if you already had it in the past and now you have the antibody to it. So it's a blood test that can be done in the lab, but currently it's not covered by OHIP. If you really want to know, you can ask your family doctor to send you for this lab test, but I think it costs about $70 at Gamma Dynacare lab, and you need a requisition to do this test, okay, if you really want to know. So once you get a result, what do you do with it? So if your PCR test, that's the the nasal swab test or the saliva test, if it comes like negative, it means you don't have the virus at the time of testing. However, it does not tell you, like if you're 5 days later, you develop symptoms. It does not mean you don't have the virus, because it can still develop afterwards, and it may not have detected it 5 days ago, right? So if you were a close contact of a positive case, you should still self-isolate, and they will tell you this. You have to isolate for up to 14 days of the exposure day. And then if you develop any new symptoms after the test, you need to go for retest again, because it could become positive if you become symptomatic, okay? But most people, if you were not, a close contact with anybody and you're negative and you remain asymptomatic, or your symptoms were getting better, it was probably just some other virus or something, then you're probably okay to go back to work, or get out of isolation. Now, if your PCR test is positive, it means you have COVID-19, and public health will definitely contact you, and they will give you more instructions, and then ask about your contacts, and to prevent further spread, right, in the community. But for this case, you would have to isolate for at least 10 days. So it used to be 14 days, but they reduced it to 10 days because they feel that you're less infectious after the 10-day mark. But some people, if they have very severe disease or if they're immunocompromised, the recommendation is actually to isolate for 20 days, just to be certain, okay? So treatment-wise for COVID, for most people, it's actually a mild disease. And we see a lot of the younger people, they might not even have symptoms, or very, very mild symptoms. And they just stay at home, do their isolation 10 days, and then they usually recover fully, and they don't really need any treatments, other than maybe a little bit of Tylenol or something for the cough, over-the-counter treatments. But for some people, especially seniors, like we said, or people who are like certain minority groups, they can be having very serious illness from COVID and require hospitalization or an ICU stay. ICU is intensive care units in the hospital. So some of the symptoms, if you do test positive COVID, that warrants you to go to emergency, include shortness of breath, like difficulty breathing, you can't speak in full sentences. If you're becoming more drowsy, more confused, your level of consciousness is decreasing, then that's when you definitely need somebody to bring you to the emergency. Or you have persistent chest pain, that's not going away. It could be a sign of bad pneumonia. So those are sometimes you have to go to the hospital, and don't just stay at home and try to recover yourself. And if you are hospitalized and you have severe disease, treatment in the hospital would include steroids called dexamethasone, and is an anti-inflammatory, seems to work for severe viral illnesses. Sometimes they might give you an antivirus called remdesivir, and it's given through the IV, so you would have to go through the hospital for that. That's supposed to help reduce the viral replication, multiplication. There's also other things that are approved by Health Canada called monoclonal antibodies. I believe President Trump, or former President Trump, got this when he was hospitalized. So it's an antibody that's targeting the virus. But it's rare cases that people would get this, really. And then there's other supportive measures, obviously oxygen to help you breathe. And then if you needed it, mechanical ventilation, meaning, connected to a tube to breathe for you. So the best thing, obviously, is prevention in the case of COVID. So you're probably seeing this everywhere, from public health, is to stay, the social distance, 2 meters apart from other people, wearing a mask that covers both your nose and the mouth, not just the mouth, because I've seen people wear improperly. Sometimes they're now even asking people to double mask just to be sure, or try to wear a medical mask if you can, because it does offer a little bit better protection than cloth masks. And obviously avoiding crowds and socializing with people outside of your home, washing your hands often, avoid touching your face to prevent infection. And of course, staying ill, if you're ill, don't go to work or other places, public places, if you're not feeling well until you're sure that it's not COVID. And then at home, you can definitely clean areas that you frequently touch, like doorknobs, or even your cell phone. People use those a lot. It could be a source of infection. And then, of course, vaccine is available, and everybody's heard this on the news. And on December 9th, Health Canada approved the first COVID vaccine, which was the Pfizer BioNTech one. And then December 23rd, the second vaccine by Moderna was also approved for use in Canada. And both of these vaccines, are based on the mRNA technology, and it's targeting that spike protein that we mentioned on the surface of the virus. Both have been found to be highly effective in clinical trials. And side effects wise, I mean, it's common like all other vaccines. Usually it's pain and swelling at the site of injection. You can get the headache, the fatigue, muscle pain for a couple of days, and maybe a low-grade fever as well. Okay, I know there are some concerns about like allergic reactions or severe allergic reactions, but that hasn't really panned out so much. Like, I mean, unless you've had severe reaction like anaphylactic reactions to a vaccine in the past or to any component of the vaccine, then it might not be recommended for you. Okay, otherwise it's actually fine for most people. Um, so here's another chart comparing the two vaccines that are approved in Canada. So the Pfizer one and Moderna, both of them require 2 doses. It's 21 days apart for the Pfizer versus 28 days for Moderna. However, that has actually been extended to up to 45 days by NACI, which is the National Advisory for Immunization in Canada. Just because of supply issues, some people may not be able to get it right at the 21 or 28 day mark, but up to 45 days later is fine for this vaccine. And because in the clinical trials, they were only studying people who were over 16 in the Pfizer and then 18 in Moderna. Right now, it's only indicated for people who are over 16 and 18 for these vaccines. So it's not for kids right now. However, I know that they are conducting studies in some of the younger population now. So it may be possible for them to get it later on once the results are out. And as you heard, some of these have very stringent kind of storage requirements. They have to be frozen like -70 for the Pfizer and -20 degrees for Moderna. However, once it's thawed, it can stay in the fridge for up to 5 days. And the effectiveness for both of them is similar because they're both mRNA, the technology. So you would expect the effectiveness to be similar between the two of them, from 94 to 95%. So the only absolute contraindication, like I said, the only reason you shouldn't get the vaccine really is if you have any allergic reaction to a bad reaction to the vaccine or any component that's listed, especially something called PEG, which is polyethylene glycol. Sorry, it's a long name. But for most people, if you've had, colonoscopy where you use this laxative, then you're probably not allergic, because this is actually very common in a lot of things, even shampoos and some skin products. So it's rare that you really have a true reaction to PEG, this PEG that's found in the vaccine. Another reason that you shouldn't get the vaccine is if you're feeling ill, if you're having fever, then you should defer the vaccine and make sure you don't have COVID already. And they also want to avoid getting these vaccines if you had any other vaccine in the last 14 days, just so that it can, make sure the immune system can be primed, work against this vaccine. Okay. Now there's some precautions that they kind of warn people about, but more about like talking to your doctor about it if you have these conditions, such as if you're immunosuppressed, if you have some kind of autoimmune disease that affects your immune system, or if you're pregnant and breastfeeding. And the only reason is because in the clinical trials, they didn't test on these people. So they're not sure how effective it is and safety-wise. I mean, safety-wise, theoretically, it should still be safe and it should work because none of them are live vaccines, right? So technically, it should be fine, but they just haven't studied it. And that's why they don't just directly recommend you to get it. But if you talk to your family doctor and they feel that the benefit is greater than the risk of getting it, then it's still recommended to do it, to get the vaccine, I mean. So this is a slide that just shows you maybe a little bit about what the mRNA, how it actually works. So that squiggly line, the red mRNA, is basically just a message. It's a messenger RNA. So it's a message that codes for that spike protein that's found on the surface of the virus. So what they do is they take that little squiggly message, put it into this lipid particle, and then when they inject it into you, it will go into your cells, incorporate it into the cells, and then your body's own machinery will kind of transcribe this and translate it into the protein, make it into that spike protein, and then present it at the surface of the cell. And then once your immune system detects that, oh, here's a spike protein that doesn't belong in our cells, it will produce antibodies against that spike protein. And it's that antibody that will protect you in the future if you are exposed to the coronavirus afterwards. Okay. So I know because it's a new technology when people never heard of it and how the vaccine was produced so fast or approved so fast, there's been a lot of, concerns or questions about hesitancy about the vaccine. And some questions that people might be worried about is, if they already had the vaccine, if they already had COVID, should they still get vaccinated? So the answer is yes, you should still get vaccinated because now you've heard of there's new variants, right? So the virus is mutating. It's possible that you can get reinfected with a new strain of the virus. So it's still a good idea to get vaccinated. And then there's also evidence of people getting this, the COVID twice, right? And we don't actually know how long the immunity from the infection can actually last. I mean, they say maybe it could last 3 to 6 months. We don't know. And then after that, are you susceptible again? Possibly. So that's why we do recommend vaccinating, even if you had the COVID infection, especially if it was a long time ago, like last year, right? Another question people might have is, can you get COVID from the vaccine? So answer is no, because it's not the actual virus. It's not the live, weakened virus that we're injecting. We're injecting this mRNA, which just gives you the message to produce that spike protein. So no, it cannot cause the actual infection. And then some people worry about this messenger RNA maybe affecting our DNA, but it's actually, even though it sounds the same, like RNA, DNA, it's actually very different. We don't actually have RNA. It's only found in viruses. And after our cell makes that spike protein from the mRNA, it actually will break down this mRNA and then it's just kind of clear from your system, okay? And then some people will ask, because there's this shortage issue or a supply issue, do you have to get the second dose to get the full protection? So the answer is yes. It's possible that you will get some protection after getting the first dose, but they said in the clinical trials, we're only about 50 to 60% effective after the first dose. So you might have heard in the news, some people after getting the first dose still tested positive for COVID because they don't have full protection. But even with the second dose, it goes up to the 95%, effectiveness. So it's still possible. There's a small risk you can still get COVID after vaccination. So this is a chart that I kind of pulled from the ministry because this is what they plan for the rollout of the vaccination program in Ontario. So we were in December, they were in this first stage where there was limited vaccine availability. So they were focusing on, hospital staff or people who work in long-term care homes and people who reside in the nursing homes. So those people, most of them are probably already at least got the first dose and hopefully will get the second dose shortly by early February. But unfortunately, because of the storage requirements of these vaccines, they kind of had to give it out in the hospitals, and only with the Moderna, where it has a lower, not the, the warmer kind of requirement, they were able to bring it into the long-term care homes and nursing homes. Okay, we're not quite at the stage 2 yet, but that's dependent on, stock of vaccines availability. So they're looking at maybe March, and that's when the next phase would be when they expand to more the community healthcare workers, like family doctors or maybe dentists, physiotherapists, and also certain seniors. And they're probably going to start with the oldest senior first. I know the plan was to start with people over 80, and then they're going to go incrementally down to 75 and above, then 70 and above in that kind of order, okay? And hopefully later they'll have open more of these mass vaccination sites, such as the one downtown at the, I think it was a convention center. Unfortunately, they had to shut down because there was no supply, but they're gonna open up more of these mass vaccination centers other than the hospitals, okay? And then finally, they said probably later in the summer, in the third phase is when it's definitely more available, and then anybody at that point who wants the vaccine should be able to get it by then. And they're hoping to vaccinate everybody by September. That's the goal. We'll see if it's really going to happen. Okay, so I think I'm gonna end soon, so we can have time for questions. But the take-home messages basically is shingles and COVID-19 are both viral illnesses that can cause serious problems in seniors. Okay, and both of them are preventable with vaccines, so consider getting vaccinated. Don't hesitate. Okay. However, like I said, none of them are 100% effective, so you still have to take your precautions, continue to follow public health advice such as social distancing, masking, and avoiding contact with other people outside your house so that we don't keep spreading this illness we can get over from this pandemic. Okay, so I think that's it for my presentation today.
Dr. Lee, there are a few questions in the chat box. Would you like
Okay.
to open up the chat box and look at the questions?
Give me a sec.
Yeah.
Can I ask a question now?
Sure. Or let's do the chat ones first, maybe.
Yeah.
Okay, so first one is, would the Shingrix vaccine interfere with the COVID ones? So as long as you spread them out, like I said, you cannot have another vaccine within 14 days of the COVID vaccine, then it shouldn't interfere. So if you skip a month before you get the COVID or the Shingrix, then it should be fine theoretically. It shouldn't interfere. Okay. Another question from Lo Lyle. So mom had shingles over 10 years ago, but she's still suffering from the post-herpetic neuralgia. Yeah. Any suggestions for pain medication? Okay, so there are medications. So it's usually the nerve pain medications, something called pregabalin or gabapentin. These are the common ones that people use, but they're prescription and they do have side effects. So some people do get quite drowsy with it and they may get constipated with it. So you'll have to see if it's appropriate for her, or else you could just take regular painkillers too, right? If she can't tolerate those nerve pain meds. But you should check with your family doctor or her family doctor about it, okay? Another question is, if we had the Shingrix vaccine, is there a time frame when we can get a second Shingrix vaccine, let's say 10 to 15 years, as the first one might not be effective anymore? Okay, so first of all, it's supposed to be 2 doses for the Shingrix one, the newer one. The second dose, like I said, was 2 to 6 months later. So as after that, though, there is no need for a booster. There's no, like, it's not in the product monograph, which means the manufacturer does not recommend it. So we don't usually do that. But you should get the 2 doses as the primary series for Shingrix. Okay. Hopefully that answered it. Next one is, I had shingles 40 years ago. Will I be immunized or do I still need to get the vaccine? Okay, so like I said, if you had shingles before, it's possible to still get it. It's low risk, probably about 5% of the population can get it more than once. So I would recommend to getting it if you are definitely older, like I'm assuming you're over 50 now, then it's still a good idea. But whether you get it for free, I don't know, because you have to be between 65 to 70 to get it for free. Otherwise, you would have to pay out of pocket for that. It may be worth it for some people. I mean, because your first time, it might have been mild because you were young, right? But if you get it older, you can get that chronic pain that we mentioned, and a lot of people do suffer from that. So it might be worthwhile to get it, the vaccine, okay? Another question from Jenny is, in addition to Shingrix, Prevnar, what other vaccines are critical to have, especially for seniors? Okay, I think those are the most important ones. So Shingrix, Prevnar, which is for pneumonia, so for some people who don't know. But that one, unfortunately, is not covered by OHIP, so you would have to pay out of pocket for that, the Prevnar 13. So you can talk to your family doctor about that. Other than that, flu shot for sure, every year I recommend that to all my senior patients. But there aren't too many other ones. I mean, you can get tetanus every 10 years if you're prone to getting cuts and stuff, but that's about it. And definitely COVID right now is an important one to get. Okay, so I think Nancy took a question from a participant. I had the Zostavax 6 years ago. Can I take Shingrix now to get more protection? So yes, the answer is yes. Next question from Maureen. I have a chronic disease, high blood pressure, and some kind of allergy to aspirin and anti-inflammatories. Can I take the COVID vaccine? So I would say yes, because I know that some people have minor allergies and they were worried about taking the COVID vaccine because of some news that came out of the UK when they first administered these vaccines. However, now they're saying that anybody who doesn't have an anaphylactic reaction, if it's just like a rash or a hive or something like that, it's not causing the swelling, the shortness of breath, the emergency kind of allergic reaction, then yes, you can still get the COVID vaccine. Okay, from Julia, is there enough tests on people taking medicine for high blood pressure, diabetes, blood thinner, and thyroid? So I don't know the exact population they tested, but I'm sure they tested on thousands of patients in the States or other places. So I'm sure some of them were diabetic and high blood pressure, and it's been shown to be fine for these people. So the 95% effectiveness is for the general population, including young and old, over 16 and 18, depending on the trial. Okay. Okay, another question is Shingrix effective for life? So the effectiveness, like I said, was 90%. It should be, because they said that there's no booster required according to the manufacturer. But of course, your immune system does get weaker when you get much older. So, and even 90% is not 100%, right? So there's still that possibility, 10%, that you could still get shingles, even though you've had the Shingrix. But as far as we know, it should be, you should get the antibody boosted, right, after getting the vaccine.
Okay. So thank you very much for your patience. We have answered all the questions in the chat box, and now we are opening the floor for any additional questions that you may have.
Regarding the shingle vaccination, is there any side effect besides, have redness or allergy? Like, for example, in some osteoporosis vaccination, you have the reflux or something like that. Will that happen in shingle too?
Not usually. It doesn't affect the gastrointestinal system so much, so it shouldn't. It will be mainly the local side effects and maybe systemic ones, like the fever and feeling unwell, but not so much gastrointestinal. It shouldn't affect that.
So it's just the side effect is only after you put the needle. That's it. Maybe a couple of days.
Yeah, a couple of days later, up to maybe a week. Some people may still have a little bit of side effect. Yeah.
Okay. We have Diana. Diana, please.
Yes, if I take the first dose of shingles at 69, then by the time I take the second one, I'm already 70.
Yeah.
Do I have to pay for it?
No, it's up to 70. So as long as you're still 70, it's fine.
Oh, okay, good. Thank you.
Yeah. You're welcome.
Anyone has any questions for Dr. Lee?
Yes, I do. Is Care First the health team doing the Shingrix injections now, or do I have to wait till the stay-home order is lifted?
Okay, so as far as I know, we are still giving vaccinations. So you do just have to talk to your doctor, and then they can schedule you with the nurse to get the vaccine. And we just do the precautions such as screening you before you come in, make sure you don't have COVID symptoms, right? And you're feeling well. So you can still get the Shingrix, yes. And we should have supply of it from public health. And right now, definitely it's the Shingrix one, not the old Zostavax.
It's good to hear. Thank you.
You're welcome.
Hi, Dr. Lee. I have a question.
Okay.
10 years ago, I have a shingles. Like certain, and now I have a certain spot still numb, the nerve still numb. So is it going to be the lifetime?
It could be if it's already 10 years, unfortunately.
Yeah, it still have certain spots.
Right, but at least it's numb and not pain, right? Pain would be worse.
No, it's numb. So that means the nerve is dead. Well,
it was damaged, and sometimes the nerve, when it regenerates, it's really slow, or if it regenerates at all, right? Sometimes it might not. So, but I think that it probably still works, right? You can still feel a little bit, right? It's not
right.
Paralyzed or something, right?
Yeah. Uncomfortable.
Right. Yeah. So there's no good treatment for that. I mean, if it's the nerve pain, there's that medication that I talked about, the Lyrica or pregabalin. But for just numbness, I don't know if it's worth it for you to take that.
I'm going to ask the doctor. It's minor. It's only sometimes I feel, but not every day.
Right.
Yeah. Okay. Thank you.
No problem.
Yes.
I have been taking the beta blocker like bisoprolol because I have some sort of like a high blood pressure and irregular heartbeat. Do you think I can still take the COVID vaccine?
Yes. Almost everybody can take the COVID vaccine except people who have that severe allergy to vaccine or any component of vaccine. So
okay. Thank you.
Welcome.
I can see the next one is Casey. Casey, would you like to open your mic and ask questions?
Yeah, okay. I had saw this about 6 or 7 years ago. And so when I approached the family doctor about this new Shingrix, because it's free, he hesitated to give me Shingrix because there's no research or that what kind of the effect on those two vaccines.
Okay, I don't feel that way because I've heard from many people actually, and even specialists, infectious disease specialists, that they do recommend getting the Shingrix even if you had shingles before.
Yeah. Okay, yeah, because I went to the website and there's no such research or result or warning. So I don't know what
Which website did you
my
go to?
family doctor come from, hesitation to give me Shingrix.
Okay. Well, I don't have that hesitation, and maybe I don't know where you looked up the information, but there should be some information somewhere that tells you that you can get Shingrix after having shingles. Maybe
Yeah,
you
okay.
might want to look up on Shingrix's own website.
Yeah, I did. I went
Oh,
to
you
the
did.
Untitled
It
website
didn't.
and nothing mentioned or give us any warning, right? But anyway, the family doctor gave me the first shot.
Okay.
And because it's free, and so finally he gave it.
Okay. Yeah, I think he did the right thing.
Okay, thank you.
Mhm.
Dr. Lee, I have a couple of more questions in the chat box. Someone called May, who has
From May.
bypass surgery over 14 years.
Yeah, now taking blood thinner. So it is fine to get the COVID vaccine. The only caveat is that if you're on a blood thinner, it's just that when they inject you, they might have to make sure they hold it longer just to stop the bleeding. That's it. But you can still get it, even if you had heart problems or whatever, any chronic problems.
Go all the way down.
Anything else?
Yeah,
Carl,
will government send us letter individually to take the COVID-19 vaccine? I don't think so.
No, they're not going to be informing everybody, but it'll go through the news outlets, right?
Yeah.
You'll hear in the news for sure. And then you should be able to call to these mass immunization sites and be able to book an appointment if you fulfill the criteria, if you're in the priority groups, right?
And one last question, yeah.
Oh, sorry. How do you know it's time to take my mom, 88 years old? So again, depend on the news. We'll probably hear about it, I guess. Can someone with ankylosing spondylitis and CMV virus take the Shingrix and COVID vaccine? Okay, so for ankylosing spondylitis, it's an autoimmune disease. CMV virus, I mean, it's probably not active right now, right? You mean a history of it. So for Shingrix, the answer is yes, definitely for both of them, because it's not the live vaccine. So anybody can get that. Oh, active? Okay, so if you're not well, then probably you should defer the vaccination until it's kind of recovered. But ankylosing spondylitis, it kind of come and go, like it flares, right? So with COVID vaccine for ankylosing spondylitis, they have a caution again because it's an autoimmune disease. They're not sure if it may flare your ankylosing spondylitis. So you just have to talk over with your doctor or maybe your specialist to see if they would recommend it for you. But it should still work. We just don't know if it will cause a flare in your condition. That's all. But if you have active disease, you probably should wait and defer the vaccination. Okay.
Any more questions?
I have a question here.
Sure.
Can you hear me?
Yep.
Okay. No, it's a very common question. I just like you to recommend what is the best way to take care of your grocery, your clothing and all that after you come in from the outside.
Right. So I know there are some people that are really cautious. They will try to wipe out everything when they buy the grocery. Personally, I haven't done that, and I do the grocery shopping in my home. So they said the risk of catching it from grocery, like inanimate objects, is very, very low. Okay, it's more for contact with people who are actually having symptoms, sneezing or coughing, on you. So I don't personally do all that, but if it makes you feel better, you can definitely wipe down, the bags or the boxes, but, things get wet, right? So I don't know how feasible it is for everything. But clothing wise, again, if you are concerned because you were kind of exposed to outside and you suspect somebody might have had symptoms of coughing around you, I mean, obviously you get home, you can change, right? And, but you would just do your laundry the same way. There's no special precautions or any special detergents or anything like that.
Is the ultraviolet lights help?
I mean, it can help with some viruses, but I'm not sure about COVID, whether it would kill it. And how would you ultraviolet your clothes, or what do you?
Well, just turn on that ultraviolet lights.
I mean, you could do that for groceries, but and clothes if you take it off, and you could do that, but I'm not sure if it really helps. I think that might be maybe a little bit too much precaution that you're taking. Yeah.
Yeah, but
it doesn't hurt, I guess. You can do it if you like.
I mean, the thing is, it is effective. if it's not effective, why bother of wasting time to do it?
Right. So
Right.
I don't think any of the infectious disease specialists will recommend that. So I don't think you should bother
But
too much time.
supposing you know, in the winter, you wear a thick coat outside. So when you come in, you cannot right away put your, you know, very thick coat, whatever it is made of, and into the laundry right away.
Right.
You can do it, you know, all the time with the outer coat.
Right.
That's my question.
Right. So I don't wash my coat all the time either, because unless you've really been close contact with somebody you suspect might have COVID, then I might do it. Otherwise, it's just, you know, if you're keeping your distance on a regular basis, then you shouldn't have to, right?
Okay. Yeah. Okay. That that helps.
Okay.
Okay. Thank you, everyone, and thank you, Dr. Lee, for such a great presentations.
Okay.
A lot of encouragement that we received in the chat box.
Okay.
And the next sessions, the next virtual health education sessions will be in March. So stay tuned. Wait for my email, and I'm still working on it. So meantime, stay well, stay safe, and thank you very much. And don't forget to fill out the polling.
Yeah, and get vaccinated.
And get vaccinated, yes.
Okay.
Thank you, Dr.
Thank you,
Lee.
Dr. Lee. Thank you, Nancy.
Thank you.
Bye-bye.
Thank you, Dr. Lee.
Okay, bye.
Thank you.